look at the evidence a little bit more. I want to talk about some of the group studies, how safe it is, tolerable it is. That position paper by the American Academy of Sleep Medicine does recommend IRT for idiopathic and PTSD associated nightmares. I did about 9 RCTs with positive results. Most of them did use waitlist controls, and they acknowledge that it can result in some negative imagery, and maybe that relates to attrition. They say that lucid dreaming therapy, it may be used for idiopathic nightmare disorder, not enough evidence for PTSD just yet. And of course, they recommend a variety of other therapies that have overlap with different features of nightmare therapies and general supportive therapies. Let's talk about the group evidence. Going back to the 80s, where Paul Tolai, a German sports gestalt psychologist, ran a couple of observational studies. They weren't controlled. They gave an intervention to engage with nightmares for self-healing. In the first study, they trained lucid dreamers in a small group of college students, and then they did a larger study and had almost 300 lucid dreaming reports. And they looked at what results in a good outcome when you're in a nightmare. They found a friendly, conciliatory approach with hostile nightmare figures tends to reduce their threatening quality, aid reconciliation in the dreams. They found that if you're aggressive or avoidant in these dreams, that leads to worse outcomes. Say you're angry in the dream or you fight back, the hostile nightmare figure gets angrier, stronger, they tighten their grip on you. And they note that the positive change, it wasn't linked with only getting lucid, it was what the dreamer did in that state. Spoormacher in 2006, a Netherlands study, did a randomized waitlist control on a nightmare population. Some of them had PTSD. It reduced nightmare frequency, but they didn't see an improvement in PTSD symptoms, and much of their participants did get lucid. Do note that waitlist controls don't really tell us a lot about ruling out placebo effects or non-specific therapy factors like support or features that would overlap with lucid dreaming therapy. It does tell us that doing this instead of nothing is helpful. Another limitation is they didn't describe what the lucid dreams were like, what was the activity. The only instruction was to confront and modify the nightmares. I almost hesitated to put the Lancy study in because it had a really questionable lucid dreaming intervention. And actually, the 2019 AASM position paper excluded it. So for the sake of time, I'm actually going to exclude it for you guys. Holtzinger, it's a group in Austria, did another group study in 2015. They used a comparable treatment control, gestalt therapy, did a lot of parts whole work. They also did another group that added on a lucid dreaming component. So most of them had nightmare disorder and different psychiatric comorbidities. Both groups did improve on nightmare frequency and sleep quality. There wasn't much difference in how much they improved, but that's a good thing. It shows us that lucid dreaming improves nightmares as much as other therapies we know can help. They also noted that people in the lucid dreaming group showed improvements faster, and they had larger improvements right away. It wasn't a wait list, but it was an unequal treatment dose, something to pay attention to as far as limitations. This same group in 2020 did another trial. They didn't use a wait list. They used what they called a credible active comparison condition for treating nightmares, and that was sleep diaries. How credible would a subject see a sleep diary as a treatment? I don't really know if that would be the case. The population certainly wasn't verified. They didn't do testing. People in this study basically just reported dreams in the last 7 days related to a stressful event. It's a very small study. It's an acute population recruited from inpatient to psychiatric aftercare, substance use in this population. The only thing they found was that the lucid dreaming therapy group reduced depression and anxiety. That doesn't really rule out the other support factors. No one really got lucid in this study, and nightmares were not reduced, and PTSD or sleep quality did not improve. Some of the people in their sample didn't even have nightmares, so there was probably a floor effect with this. They're measuring symptoms without even verifying clinical diagnoses. That's a significant limitation. Like I said, sleep diaries are poor treatment control. They're unlikely to be perceived as credible. The control group doesn't get the same treatment dose as the lucid dreaming group. And of course, this was a small sample, lots of attrition. Yount did a study in 2023. This is a USA-based group from the Institute of Noetic Sciences. This is a single group, a pilot study. It's a within subject design, so no control group yet, where they did a 6-day online healing workshop with Charlie Morley, who's a popular author, a teacher of lucid dreaming, influencer. The design gave lucid dreaming instruction, relaxation and meditation instruction, sleep hygiene. They had a psychotherapist from the UK that supervised teachings and was available for support. This was a PTSD population per self-report checklist, not verifying any diagnoses, and they recruited worldwide, but mostly from the US. They had a decent sized group, 49 subjects. They found that there was a pretty large reduction in PTSD and nightmares, improved well-being, less negative affect. They had a salivary measure of like cortisol that didn't show a change. A lot of the group did get lucid, and they noted that at least half enacted their plan to heal themselves in their lucid dreams. Limitations include symptom measures without verifying clinical diagnoses. A lot of the subjects improved without actually inducing a lucid dream. This is a common issue in understanding the mechanisms of lucid dreaming therapy. When you use a teacher like Charlie Morley, who's very charismatic, if you know him, and inspiring, that could amplify expectancy effects and create a selection bias because of the instructor characteristics. You know, if you have a Tony Robbins run a PTSD group, for example, there's going to be a good amount of people that get better. They see everyone else around them getting better and they're inspired by it. So does that translate to other therapists? It's a question to ask. They didn't really report any case examples either of the healing intentions or healing lucid dreams. They followed up with a bigger study, this time using a waitlist control. The control group actually wasn't fully waitlist, though they called it that. They were filling out dream recall measures. Did the same workshop. They did acknowledge a little more. There was some components of psychotherapy group support, normalizing, validating PTSD experiences, being available when you're challenged by the material. They had 99 that made it into the study, also recruited worldwide. The majority had experience with lucid dreams, though. And it just kind of shows when you implement an intervention like this and you recruit from social media, the popular author, you're going to get a little bit of a selection bias. So most people, they were already experienced with lucid dreams, but it does show us what happens when you get a population like lucid dreamers that engage in this as a therapy. And there's a lot of lucid dreamers in the world. You know, at least 20% are having them once a month. This could really help that population. I think this study really demonstrates this because they saw a pretty significant effect, reducing PTSD and nightmare frequency and distress. There wasn't a group difference in inducing lucid dreams or how well they engaged with it. Both groups had at least one lucid dream. A little bit more in the lucid dreaming group achieved that healing lucid dream, or reported they did. Limitations to this are the same as the Yount 2003 study. Important to keep in mind that wait lists are poor controls. We don't really know if lucid dreaming is helping more than non-specific therapy factors at this point. Dream recall measures might also, especially in a lucid dreaming group, be helping them get lucid. So not necessarily the best control group, could be improved in the future. They also modified it. One of the questions on their rating scale commonly use a dream lucidity questionnaire that asks, did you get to enact your pre-planned intention, which is usually a scale 0 to 4, but they modified this to be binary. So yes or no, did you enact your healing intention? So that's a classic way to inflate type 1 air, and there's no explanation why they did it. There's also a bit of a legal ethical gray zone around unlicensed therapy being practiced here. And what really concerns me is, why are we still doing waitlist control studies? We have a couple of decades now knowing that imagery rehearsal therapy helps. And if you're gonna put people in a study and delay their treatment for however long is the length of your study and the follow-up period, maybe up to 6 weeks, that's definitely an ethical gray zone, because there are treatments available that could help them, prevent them from getting worse. So I think there should be a little bit more dialogue around these sort of opposing viewpoints rather than completely omitting it from these studies. And I feel more strongly about no longer using waitlist control groups for these clinical studies, even more strongly about that than the red tape around outdated interjurisdictional practice. I think there should be more dialogue about this, and psychologists are responsible for the profession and educating people around this. So I thought it was important to keep this in mind as you continue to evaluate the new research that keeps coming out. So to summarize the evidence, lucid dreaming is promising, especially for nightmares, potentially for broader mental health. Most studies have poor control of the independent variable. They don't verify diagnoses. They don't directly examine potential negative effects. They're not tracking systematically. Also, if a subject drops out, we don't know the reason why. It could have been because the therapy wasn't for them. And it would be beneficial to have more reports and case examples. So future needs in this area, we need more comparable treatment control groups like imagery rehearsal therapy. Does lucid dreaming work better than a therapy that's pretty low cost, low training demands for the patient and therapist? Does it add anything to that? We shouldn't be using waitlists anymore. Use a comparable treatment control. Keep in mind, those active control groups, they really minimally address placebo effects, and they're often imperfect. We need more diagnostic verification, tracking of adverse events, more case vignettes, and clarifying mechanisms. Why do some people improve when they do lucid dreaming therapy, even though they don't lucid dream? And does how we change the dream even matter?
Hello, Dr. Lamarca. I have a question. You mentioned that the waiting list controls are no longer a great thing to do. So, would having our RIT image rehearsal therapy, would that be good control against the
It's a perfect control. It's a comparable treatment control. It's one we already know works. If IRT improves nightmares and lucid dreaming does, we know that they're both effective. So you could use one over the other. That would also give us insights to be able to analyze subgroups. Did some clients that did lucid dreaming improve more than others? Were there subsets that responded to it better than they did with IRT? And also, what was happening in the rescripted versions of their dreams and the dreams themselves? This would be more informative about why lucid dreaming adds anything to therapies we already know work. And really, just that fact that we're withholding treatment from people just for the sake of science, it shouldn't be happening anymore at this point. There's plenty of evidence to know that these are therapies that help.
Thank you. That sounds good. It sounds like it's both quantitative and the qualitative. It's a mixed method study.
I would like to see more qualitative perspectives integrated into the quantitative. When there's group level studies, it's all numbers and there was a clinically significant improvement. But with something as new and poorly understood as lucid dreaming therapy, there should be those qualitative and subjective phenomenological aspects that would be really informative. Great question.
And I did a quick search. I haven't found particularly studies comparing image rehearsal therapy plus lucid dreaming. Am I missing something? Have you found them?
They should have been done by now. It seems so simple. No, they haven't been done, but I will say, I forget exactly the authors. They didn't do a group study. That's why I didn't go over it, but they did a small pilot, very, very small, actually looking at this. They incorporated targeted memory activation. So they're in the lab and they're giving cues, but it did have a component of IRT versus lucid dreaming therapy. So if they do They didn't find a difference yet. They only had like 3 subjects per group. But if they do a bigger study on that, that might answer some important questions.
Thank you, Dr. Lamarca. Looking forward to Foundations 2. I guess just one quick thought. You're bringing up a good point why these studies are still done with wait lists or control groups when there's the evidence is just overwhelming at this point. Why do you think this is done? The initial thought is that people just want to publish something that shows that they have a positive effect. So if you compare anything that we know has a positive effect against a control, you're able to just put out literature that's compelling. Do you think it's just the nature of just wanting to have positive results for something? So they created a study that's just invariably going to give positive results simply because I'll use your word, unethically withholding a treatment that we know helps.
I don't think it's malicious. I think science is hard. And these aren't like major clinical controlled trials at reputable universities that are studying this. You'll get like a small group wanting to just show, hey, look at this is helping. And science, it's difficult, even trying to like differentiate types of controls. What's a comparable treatment control versus a credible one versus a sham control, an active control, a waitlist control? That's difficult to really parse out. I know it can be done better though, and it should be done better. I don't think there's any malintent. I know in academia there's pressure to publish and have positive results. So I hear what you're saying with that. But for the most part, I think most people are well-intended and want to show that this is something that can be helpful to people. And it really is our job as clinicians to educate people and researchers and open up a dialogue and discourse on how we should be designing these studies, be open about criticisms or where you're skeptical. I think people tend to shy away from that. And sometimes researchers can be defensive. They don't want to hear critiques of their researchers as well. And that really is a disservice to the spirit of science. And my point around this is that I think there should be more open dialogue. And I think there's positive aspects of both opposing viewpoints. But the more dialogue we have about this and open up that discourse, I think the more we'll see better and faster improvements in the science of this area.